don't stop. Don't stop. Don't stop. Don't stop. Don't.
Learn about pneumonia. Pneumonia is a common lung infection caused by bacteria, a virus, or fungi. It is often spread via coughing, sneezing, touching, or even breathing, and those who don't exhibit symptoms can also spread the illness. Classification: A-pneumonia is most commonly classified by where or how it was acquired. 1. Community acquired. 2. Aspiration. 3. Healthcare associated. 4. Hospital acquired. 5. Ventilator associated pneumonia. B. It may also be classified by the area of lung affected. 1. Lobar 6 pneumonia. 2. Bronchial pneumonia. 3. Acute interstitial pneumonia, C. By the causative organism. D-pneumonia in children may additionally be classified based on signs and symptoms as non-severe, severe, or very severe. Signs and symptoms: 1. Productive cough, fever. 2. Shaking chills, shortness of breath. 3. Sharp or stabbing chest pain during deep breaths. 4. And an increased rate of breathing. 5. In elderly people, confusion may be the most prominent sign. Asterisk: the typical signs and symptoms in children under 5 are: 1. Fever. 2. Cough. 3. Fast or difficult breathing. Asterisk: fever is not very specific, as it occurs in many other common illnesses and may be absent in those with severe disease, malnutrition, or in the elderly. Asterisk: in addition, a cough is frequently absent in children less than 2 months old. 4. More severe signs and symptoms in children may include: 5. Blue-tinged skin. 6. Unwillingness to drink, convulsions. 7. Ongoing vomiting, extremes of temperature. 8. A decreased level of consciousness. Asterisk: bacterial and viral cases of pneumonia usually result in similar symptoms. Asterisk: some causes are associated with classic, but non-specific, clinical characteristics. 9. Pneumonia caused by Legionella may occur with abdominal pain, diarrhea, or confusion. 10. Pneumonia caused by Streptococcus pneumoniae is associated with rusty-colored sputum. 11. Pneumonia caused by Klebsiella may have bloody sputum, often described as currant jelly. 12. Bloody sputum, known as hemoptysis, may also occur with A. Tuberculosis, B. gram-negative pneumonia, C. Lung abscesses, D. Acute bronchitis. 13. Pneumonia caused by Mycoplasma pneumoniae may occur in association with A. Swelling of the lymph nodes in the neck, B. Joint pain, C. Middle ear infection. 14. Viral pneumonia presents more commonly with wheezing than bacterial pneumonia. Causes of pneumonia: pneumonia is due to infections caused primarily by 1. Bacteria, 2. Viruses, 3. Fungi, 4. Parasites. 5. Mixed infections with both viruses and bacteria may occur in roughly 45% of infections in children and 15% of infections in adults. 6. A causative agent may not be isolated in approximately half of cases despite careful testing. 7. The term pneumonia is sometimes more broadly applied to any condition resulting in inflammation of the lungs, caused for example by autoimmune diseases, chemical burns, or drug reactions. However, this inflammation is more accurately referred to as pneumonitis. 8. Factors that predispose to pneumonia include: A. Smoking, immunodeficiency, B. Alcoholism, C. Chronic obstructive pulmonary disease, D. Asthma, E. Chronic kidney disease, F. Liver disease, G. Old age. H. Additional risks in children include not being breastfed, I. Exposure to cigarettes or air pollution, J. Malnutrition and poverty. K. Proton pump inhibitors or H2 blockers L-. Approximately 10% of people who require mechanical ventilation develop ventilator-associated pneumonia. M. People with gastric feeding tube have an increased risk of developing of aspiration pneumonia. N. For people with specific variants of FER gene, the risk of death is reduced in sepsis caused by pneumonia. M. However, for those with TLR6 variants, the risk of getting Legionnaire's disease is increased. 1. Bacteria cause pneumonia. Bacteria are the most common cause of community-acquired pneumonia, CAP, with Streptococcus pneumoniae isolated in nearly 50% of cases. B. Haemophilus influenza in 20%, D. Chlamydophila pneumoniae in 13%, E. Mycoplasma pneumoniae in 3% of cases. F. Staphylococcus aureus. G. Moraxilla catarrhalis. H. Legionella pneumophila. I. gram-negative bacilli. J. Drug-resistant Streptococcus pneumoniae, DRSP. K. Methicillin-resistant Staphylococcus aureus, MRSA. L. Alcoholism is associated with Streptococcus pneumoniae. Anaerobic organisms. Mycobacterium tuberculosis. M. Smoking facilitates the effects of Streptococcus pneumoniae. Haemophilus influenza. Moraxilla catarrhalis. Legionella pneumophila. N. Exposure to birds is associated with Chlamydia psittaci, O. Farm animals with Coxella burnetii, P. Cystic fibrosis with Pseudomonas aeruginosa and Staphylococcus aureus. Streptococcus pneumoniae is more common in the winter, and it should be suspected in persons aspirating a large amount of anaerobic organisms. 2. Viruses causes pneumonia, in adults, viruses account for approximately a third and in children for about 15% of pneumonia cases. Commonly implicated agents include rhinoviruses, coronaviruses, influenza virus, respiratory syncytial virus, RSV, adenovirus, and parainfluenza. Herpes simplex virus rarely causes pneumonia, except in groups such as newborns, persons with cancer, transplant recipients, people with significant burns. People following organ transplantation or those otherwise immunocompromised present high rates of cytomegalovirus pneumonia. Those with viral infections may be secondarily infected with the bacteria, Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza. Different viruses predominate at different periods of the year. During flu season, for example, influenza may account for over half of all viral cases. Outbreaks of other viruses also occasionally occur, including hantaviruses and coronavirus. 3. Fungi causes pneumonia. Fungal pneumonia is uncommon, but occurs more commonly in individuals with weakened immune systems due to AIDS, immunosuppressive drugs, other medical problems. It is most often caused by 1. Histoplasma capsulatum, 2. Blastomyces, 3. Cryptococcus neoformans, 4. Pneumocystis jirovecii, Pneumocystis pneumonia, or PCP, 5. Coccidioides immitis. 6. Histoplasmosis is most common in the Mississippi River Basin, and coccidioidomycosis is most common in the southwestern United States. The number of cases has been increasing in the later half of the 20th century due to increasing travel and rates of immunosuppression in the population. For people infected with HIV/AIDS, PCP is a common opportunistic infection. 4. Parasites causes pneumonia. A variety of parasites can affect the lungs, including 1. Toxoplasma gondii, 2. Strongyloides stercoralis, 3. Ascaris lumbricoides, 4. Plasmodium malariae. These organisms typically enter the body through direct contact with the skin, ingestion, or via an insect vector. Except for Paragonimus westermanni, most parasites do not affect specifically the lungs but involve the lung secondarily to other sites. Ascaris and Strongyloides genera stimulate a strong eosinophilic reaction, which may result in eosinophilic pneumonia. In other infections, such as malaria, lung involvement is due primarily to cytokine-induced systemic inflammation. 5. Non-infectious causes pneumonia. Idiopathic interstitial pneumonia or non-infectious pneumonia is a class of diffuse lung diseases. They include diffuse alveolar damage, organizing pneumonia, nonspecific interstitial pneumonia, lymphocytic interstitial pneumonia, desquamative interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, usual interstitial pneumonia. Lipoid pneumonia is another rare cause due to lipids entering the lung. These lipids can either be inhaled or from lipids within the body. Mechanisms of pneumonia. 1. Pneumonia fills the lungs alveoli with fluid, hindering oxygenation. 2. The alveolus on the left is normal, whereas the one on the right is full of fluid from pneumonia. 3. Pneumonia frequently starts as an upper respiratory tract infection that moves into the lower respiratory tract. 4. It is a type of pneumonitis, lung inflammation. 5. The normal flora of the upper airway gives protection by competing with pathogens for nutrients. 7. In the lower airways, reflexes of the glottis, actions of complement proteins and immunoglobulins are important for protection. Microaspiration of contaminated secretions can infect the lower airways and cause pneumonia. 8. The virulence of the organism, amount of the organisms to start an infection and body immune response against the infection all determines the progress of pneumonia. Bacterial pneumonia mechanisms of action. 1. Most bacteria enter the lungs via small aspirations of organisms residing in the throat or nose. 2. Half of normal people have these small aspirations during sleep. 3. While the throat always contains bacteria, potentially infectious ones reside there only at certain times and under certain conditions. 4. A minority of types of bacteria such as Mycobacterium tuberculosis and Legionella pneumophila reach the lungs via contaminated airborne droplets. 5. Bacteria can spread also via the blood. 6. Once in the lungs, bacteria may invade the spaces between cells and between alveoli, where the macrophages and neutrophils white blood cells attempt to inactivate the bacteria. Defensive. 7. The neutrophils also release cytokines, causing a general activation of the immune system. 8. This leads to the fever, chills, and fatigue common in bacterial pneumonia. 9. The neutrophils, bacteria, and fluid from surrounding blood vessels fill the alveoli, resulting in the consolidation seen on chest X-ray. Viral pneumonia mechanisms of action. 1. Viruses may reach the lung by a number of different routes. 2. Respiratory syncytial virus is typically contracted when people touch contaminated objects and then they touch their eyes or nose. 3. Other viral infections occur when contaminated airborne droplets are inhaled through the mouth or nose. 4. Once in the upper airway, the viruses may make their way in the lungs, where they invade the cells lining the airways, alveoli, or lung parenchyma. 5. Some viruses such as measles and herpes simplex may reach the lungs via the blood. 6. The invasion of the lungs may lead to varying degrees of cell death. 8. When the immune system responds to the infection, even more lung damage may occur. 9. Primarily white blood cells, mainly mononuclear cells, generate the inflammation. 10. As well as damaging the lungs, many viruses simultaneously affect other organs and thus disrupt other body functions. 11. Viruses also make the body more susceptible to bacterial infections. In this way, bacterial pneumonia can occur at the same time as viral pneumonia. Diagnosis of pneumonia. 1. Pneumonia is typically diagnosed based on a combination of physical signs and a chest X-ray. 2. In adults with normal vital signs and a normal lung examination, the diagnosis is unlikely. 3. However, the underlying cause can be difficult to confirm, as there is no definitive test able to distinguish between bacterial and non-bacterial origin. 4. The overall impression of a physician appears to be at least as good as decision rules for making or excluding the diagnosis. The World Health Organization has defined pneumonia in children clinically based on either A. Cough, B. Difficulty breathing, C. A rapid respiratory rate, D. Chest indrawing, E. A decreased level of consciousness. F. A rapid respiratory rate is defined as greater than 60 breaths per minute in children under 2 months old. Greater than 50 breaths per minute in children 2 months to 1 year old, or greater than 40 breaths per minute in children 1 to 5 years old. G. In children, low oxygen levels and lower chest indrawing are more sensitive than hearing chest crackles with a stethoscope or increased respiratory rate. H. Grunting and nasal flaring may be other useful signs in children less than 5 years old. I. Lack of wheezing is an indicator of Mycoplasma pneumoniae in children with pneumonia. 2. But as an indicator it is not accurate enough to decide whether or not macrolide treatment should be used. The presence of chest pain in children with pneumonia doubles the probability of Mycoplasma pneumoniae. In general, in adults, investigations are not needed in mild cases. There is a very low risk of pneumonia if all vital signs and auscultation are normal. In persons requiring hospitalization, 1 pulse oximetry, 2 chest radiography, 3 blood tests, including a complete blood count, serum electrolytes, C-reactive protein level, D liver function tests, are recommended. 4 procalcitonin may help determine the cause and support who should receive antibiotics. Antibiotics is encouraged if procalcitonin level reaches 0.25 μg/L, strongly encouraged if it reaches 0.5 μg/L, and strongly discouraged if the level is below 0.10 μg/L. 5 For those with CRP less than 20 mg/L without convincing evidence of pneumonia, antibiotics are not recommended. 6 The diagnosis of influenza-like illness can be made based on the signs and symptoms, however, confirmation of an influenza infection requires testing. Thus, treatment is frequently based on the presence of influenza in the community or a rapid influenza test. 2 Physical examinations. Physical examination may sometimes reveal 1 low blood pressure, 2 high heart rate, 3 oxygen saturation. 4 The respiratory rate may be expansion on the affected side. 5 Harsh breath faster than normal, and this may occur a day or 2 before other signs. 6 Examination of the chest may be normal, but it may show decreased chest sounds from the larger airways that are transmitted through the inflamed lung are termed bronchial breathing and are heard on auscultation with a stethoscope. 7 Crackles, rowels, may be heard over the affected area during inspiration. 8 Percussion may be dulled over the affected lung, and increased. 9 Vocal resonance distinguishes pneumonia from a pleural effusion. 3 Imaging for pneumonia diagnosis. 1 A chest radiograph is frequently used in diagnosis. 2 In people with mild disease, imaging is needed only in those with potential complications, those not having improved with treatment, or those in which the cause is uncertain. 3 If a person is sufficiently sick to require hospitalization, a chest radiograph is recommended. 4 Findings do not always match the severity of disease and do not reliably separate between bacterial infection and viral infection. 5 X-ray presentations of pneumonia may be classified as 1 Lobar pneumonia, 2 Bronchopneumonia, 3 Lobular pneumonia, 4 Interstitial pneumonia. Bacterial, community-acquired pneumonia classically show a lung consolidation of 1 lung segmental lobe, which is known as lobar pneumonia. B. Aspiration pneumonia may present with bilateral opacities primarily in the bases of the lungs and on the right side. C. Radiographs of viral pneumonia may appear normal, appear hyperinflated, have bilateral patchy areas. Present similar to bacterial pneumonia with lobar consolidation. Asterisk radiologic findings may not be present in the early stages of the disease, especially in the presence of dehydration, may be difficult to be interpreted in the obese. Those with a history of lung disease. D. Complications such as pleural effusion may also be found on chest radiographs. Lateral chest radiograph can increase the diagnostic accuracy of lung consolidation and pleural effusion. D. A CT scan can give additional information in indeterminate cases. CT scan can also provide more details in those with an unclear chest radiograph, for example occult pneumonia in chronic obstructive pulmonary disease. Is able to exclude pulmonary embolism. Fungal pneumonia. Detecting lung abscess in those who are not responding to treatments. However, CT scan is more expensive, has a higher dose of radiation, and cannot be done at bedside. 4 Lung ultrasound for pneumonia diagnosis, may also be useful in helping to make the diagnosis. Ultrasound is radiation-free and can be done at bedside. However, ultrasound requires specific skills to operate the machine and interpret the findings. It may be more accurate than chest X-ray. 5 Microbiology for pneumonia diagnosis. A. For people who do not respond to treatment, sputum culture should be considered, and culture for Mycobacterium tuberculosis should be carried out in persons with a chronic productive cough. B. Microbiological evaluation is also indicated in severe pneumonia, alcoholism, asplenia, immunosuppression, HIV infection, those being empirically treated for MRSA of Pseudomonas. C. Although positive blood culture and pleural fluid culture definitively establish the diagnosis of the type of microorganism involved, a positive sputum culture has to be interpreted with care for the possibility of colonization of respiratory tract. Testing for other specific organisms may be recommended during outbreaks, for public health reasons. F. In those hospitalized for severe disease, both sputum and blood cultures are recommended, as well as testing the urine for antigens to Legionella and Streptococcus. G. Viral infections can be confirmed via detection of either the virus or its antigens with culture or polymerase chain reaction, PCR, among other techniques. H. Mycoplasma, Legionella, Streptococcus, and chlamydia can also be detected using PCR techniques on bronchoalveolar lavage and nasopharyngeal swab. The causative agent is determined in only 15% of cases with routine microbiological tests. Healthcare, associated pneumonia, HCAP. Healthcare, associated pneumonia, HCAP, is an infection associated with recent exposure to the healthcare system, including hospital, outpatient clinic, nursing home, dialysis center, chemotherapy treatment. Home care. HCAP is sometimes called MCAP, medical care, associated pneumonia. People may become infected with pneumonia in a hospital. This is defined as pneumonia not present at the time of admission. Symptoms must start at least 48 hours after admission. It is likely to involve hospital-acquired infections, with higher risk of multi-drug resistant pathogens. People in a hospital often have other medical conditions, which may make them more susceptible to pathogens in the hospital. Ventilator-associated pneumonia occurs in people breathing with the help of mechanical ventilation. Ventilator-associated pneumonia is specifically defined as pneumonia that arises more than 48 to 72 hours after endotracheal intubation. Differential diagnosis to pneumonia. Several diseases can present with similar signs and symptoms to pneumonia, such as chronic obstructive pulmonary disease, asthma, pulmonary edema, bronchiectasis, lung cancer, pulmonary emboli. Unlike pneumonia, asthma, and COPD typically present with wheezing, pulmonary edema presents with an abnormal electrocardiogram, cancer and bronchiectasis present with a cough of longer duration, pulmonary emboli presents with acute onset sharp chest pain and shortness of breath. Mild pneumonia should be differentiated from upper respiratory tract infection, URTI. Severe pneumonia should be differentiated from acute heart failure. Pulmonary infiltrates that resolved after giving mechanical ventilation should point to heart failure and atelectasis rather than pneumonia. For recurrent pneumonia, underlying lung cancer, metastasis, tuberculosis, foreign body, immunosuppression, hypersensitivity should be sought after.